So there are basically three categories that I would probably think about and highlight as being the most important therapeutic strategies under development right now that we really would pin our hopes on for the future. Starting with ER-positive disease, I think my personal hope is that now that the CDK4/6 inhibitors have moved into the adjuvant setting, that they can really cause true senescence of micrometastatic disease, and that we will see after 2 years of the CDK4/6 inhibitors in the adjuvant setting that the curves will continue to pull apart, and there'll be actually more patients that are actually cured, and we'll get away from this issue of needing to continue endocrine therapy for, sometimes 10 or 15 years if you have very, very high-risk patients. So that's something I hope, and then if we can ever figure out how to predict whose cancers will actually senesce with the CDK4/6 in the adjuvant setting, that would be unbelievable. The other agents that I think are very important are the Pi3 Kinase Inhibitor, the more alpha-specific that we'll be hearing data in the short term about. So hopefully we'll see in certain subpopulations, those with PIK3CA mutations, for example, we'll see good benefit, we hope. The other is the TORC1, TORC2 inhibitors. I think the data that are emerging with those so far, I think are promising. And that'll be great. Again, it's going to be subsets, which patients may be able to take a TORC1, TORC2 inhibitor, for example, even in the adjuvant setting eventually, that might be able to substantially improve their overall outcome. So that's very, we know that the Pi3 kinase pathway is so important. We know, for example, that the estrogen receptor heterodimerizes with the insulin-like growth factor receptor. We have a lot of problems with overweight and obesity, and we know that those patients have a poor prognosis, likely multifactorial, but signaling down through insulin receptor and et cetera. So is blockade of that Pi3 kinase pathway along with the estrogen receptor is going to help those patients whose prognosis is poorer who are overweight or obese, et cetera. So that's one category that I think is very, very interesting. The second category, of course, is the checkpoint inhibitors as a place to start. Of course, there are a lot of agents being looked at in the immunotherapy space, but I expect that in metastatic triple-negative breast cancer, as well as in high-risk preoperative treatment of triple-negative breast cancer, I'll be very surprised if the ongoing phase 3 trials are not positive. I predict that even as soon as 2018, we'll have data in the metastatic setting that will really change how we treat metastatic triple-negative breast cancer. And I'm very impressed with the data we have so far in the preoperative setting. And those trials are accruing very quickly, with pathologic complete response as the primary endpoint that could lead to accelerated approval and clinical availability, while phase 3s are ongoing in the adjuvant setting to finish up, to get those. So I think I hope that those exciting data will be on us very, very quickly. So that's going to be a great step forward. We really need that in the triple-negative space. Then the issue is, how can we make more tumors immunologically vulnerable, to killing by the immune system with the checkpoint inhibitors? I really think that's where a lot of the DNA repair inhibitors come in. So many of our cancers, triple-negative breast cancer, for example, there really are defects in most of them with homologous recombination. They have either a germline or more likely a somatic mutation that really inhibits their ability to repair double-strand breaks. As a result, you get compensatory upregulation of other pathways, non-homologous end joining, base excision repair, et cetera. And I really think that inhibiting these other compensatory pathways and then unmasking this baseline of homologous recombination deficiency is a really path forward to have these cancers really killed by cytotoxic therapies, that such as the platinums or doxorubicin that can really work in the setting of homologous recombination deficiency. But also there's such a crosstalk between DNA repair pathway deficiency and the success of the checkpoint inhibitors. When cells have a lot of double-strand breaks, this really incites the pathways, such as the GAS-STING pathway, that can then lead to checkpoint inhibitors being really, really effective. So the ability for any given cancer cell or subtype, and this will help not only triple negative, but some of the aggressive ER positive breast cancers where we know they're homologous recombination deficiency. I think eventually we're going to have to know what are the real DNA repair deficiencies for each of the cancers, because all, or pretty close to all, of the cancers do have some deficits in DNA repair. It's one of the hallmarks of cancer, isn't it? And so understanding which of the pathways have been taken out and what are the compensatory mechanisms, I think, is going to be ultimately essential for all subtypes of breast cancer. So it's terrific that there really are large portfolios of agents, WEE1 inhibitors, ATR inhibitors, ATM inhibitors, inhibitors of DNA PK, of course, the PARP inhibitors, et cetera. So we have a lot of the tools. It's just a matter now of some of the diagnostics to understand which of these pathways are deficient, and so which ones to go after. So that's where I think we're heading in the future.